hyperthyroid استكمالا لبقيه التوبيك المهمه في الثيرويد. hyperthyroidism in pregnancy, we must know the situation. The situation is the human chorionic gonadotrophin rising associated with this era of changes of hormone. We all must know that TSH doesn't pass the placenta, so no harm effect. But the T4 and the levothyroxine is very important for the fetus development itself. The TSH receptor antibody and iodine increase or decrease are associated with either hyperfunction or hypofunction. What about the treatment use or tool? The radioactive iodine can destruct the fetus thyroid. The propyl sericin and methimazole have some effect on the fetus, and we will see it. The propranolol also have some effect, and we will see it. This is the percentage thyroid nodule. It's definitely with pregnancy the highest rate. The subclinical, as Dr. Ghada said, is the second in association with pregnancy, and then the overt hypo or hyperthyroidism come at the end of the list. Again, the guideline, as Prof. Ihab said, the same. We use it as a guide because this is the last one available, comfortable, and include all the knowledge. Of course, hyperthyroidism of pregnancy is a very, very important harmful condition. What is the cause? Thyroid illness, as we know in the textbook, may be non-autoimmune thyroid disease, may be gestational transient thyrotoxicosis, which is a benign condition, sometimes multiple gestation, sometimes some trophoblastic disease, uterine like tumor, hyperplacentosis, hyperfunction placenta, ovarian multicyst, the TSH receptor mutation, and this is a very rare TSH producing pituitary adenoma. And iatrogenic, and some drug can cause this. What about the guideline told us? The guideline told us how to differentiate between the benign condition and the Graves' disease. Very simple. In both, we will find TSH are low, and we find the T4 are rising. But according to the secret of the hormone, if you find T4 more than T3, think of thyrotoxicosis. If you find T3 more than T4, think of thyroid illness itself. Of course, a trap go with Graves' disease. The trap, the TSH receptor antibody level. The medical history can help, as we see later on. The physical examination can help. Human chorionic gonadotrophin measurement are of no value to differentiate, so don't use it. Radioactive iodine is totally forbidden in pregnant women. How can we differentiate between Graves and this benign condition? It's very important to give treatment or not to give treatment. Of course, if you have past history, family history of autoimmunity, if you have hyperthyroid picture, rising temperature, feel hotness, marked loss of weight, tremors, night sweat, all this go with more Graves than gestational. You have a goiter of salmopsy, the trap and TPO, both of them, not TPO only, TPO and the trap, both of them, if you find, or any one of them, go with Graves, not with gestational. So again, to the guideline, how to treat: rehydrate the patient, treat the vomiting, antithyroid not recommended, beta blocker can be considered. What about the Graves, the core of our lecture, the Graves disease? Before pregnancy, you must sit with the family, sit with the female and her husband, say that about complexity of this disease and how that it affects our outcome. Of course, we must have a stable euthyroid before allowing pregnancy. The definition of a stable euthyroid means 2 reading 1 month apart by stable same dose of antithyroid. This is mean stable. If you find your reading stable in 2 or 3 month sequences, you can allow a pregnancy at that time. A treatment option before pregnancy, the 3 modules are allowed. We can give radioactive, you can do a surgery, you can keep the medications. Radioactive prior to the pregnancy, first, it's not the common tool to be used before pregnancy, but if you have a high trap, please avoid the radioactive. If you have a very young female, if you have severe form of Graves' disease, avoid using this radioactive before pregnancy because the response is very poor. You must do a pregnancy test, even routine, any childbearing woman, even if you do a technetium diagnostic tool for isotope. Please do it. Pregnancy, write it in your prescription. The pregnancy must be delayed 6 months. You must write a word for the female that you not allowed to be pregnant for 6 months at least. Here in Egypt, we sometimes give 1 year to be more comfortable, to be the safe. This is the complication of hyperthyroidism with pregnancy. That's why I told you from the start, it's not an easy mission. This is the list of the female, and this is the list of the fetus and the neonatal outcome. I will not go through, but yeah, it's a very big list that affect our mother and her fetus. What about the birth defect associated with the medication? Methimazole, carbimazole are the same. Here in Egypt, we have carbimazole and we have numericazole, the other one, but methimazole, it's not common here in Egypt, but it's the same metabolite like for carbimazole. We have aplasia cutis, skin defect. I didn't see it in all my life, and even my professor didn't see it, but if you have it, it's very not that big issue. Conal atresia, we have conal atresia or esophageal atresia, برضه very rare. الأمفالوسيل, there is no defect في البروتينية أو الwall of the abdomen. Sometimes urinary tract malformation, IDs, VSD, some small acilia absent of nipple in male, developmental delay. All of these are complications. Propyl uracil have sinus, pre-auricular sinus, and urinary tract inflammation. This is some of the side effects which is very rare. Some side effect, basic side that we give to the student to know the side effect of the drug. Side effect of the drug, most of them, alhamdulillah, they are a little bit. Urticaria, arthralgias, sometimes polyarthritis, sometimes autoimmune disease, but the very hazardous or risky one that we are afraid of is the agranulocytosis. As we know, that must we stop the medication and assess the condition. It usually occurs in the first 3 months after starting treatment. The liver effect of the drug is very well known to all of us. The methimazole causes cholestatic dysfunction, and discontinuation will correct the condition. Follow-up of the liver enzyme is very important. Propyl uracil, 2 forms of liver. One of them are rising of liver enzyme, and sometimes it causes a very hazardous hepatic necrosis that even need a liver transplant, which is very rare, but is very dangerous to our patient. Again, back to the guideline. How to manage graves during pregnancy. To manage it, we must first confirm the pregnancy, of course. We know the doses to be used in the pregnancies, and the beta blocker is allowed, but please, for a short period, from 2 to 6 weeks only, to avoid the hazard of propranolol, which is one of the allowed beta blocker during pregnancy. Give it for short time to avoid the intrauterine growth retardation, hypoglycemia, fetal bradycardias. So, if your patients have controlled thyroid profile on a minimal dose of methimazole, in such a case, the physician should consider discontinuing this medication and follow up by TRAP and doing the function later on. So you can go in your pregnancy as if we stop that medication and follow up even outside the box. We use more frequently every 2 weeks. Once we stable, you can every 4 weeks. At each assessment, you must assess the clinical and the biochemical. If your patient needs a high dose to control her, keep the medication. The guideline told us that propyl uracil can be the safest one in the first trimester, 16 weeks. The old belief before this guideline that propyl uracil must be all over the pregnancy, but in this guideline, according to some evidence that collected at that time, they said you can give propyl uracil during the early pregnancy, and once the 16 weeks end, you can use methimazole or keep propyl uracil. But this statement is very important. They said after 16 weeks, it's unclear whether shifting from propylsalicylate and methimazole helping your patient, because you may lose your control in your patients. That's why it's left to your decision. What about the principle of testing our patient during pregnancy? Of course, the same, every 2 to 4 weeks, and we can extend every 4 to 6 weeks. We need our target, as in diabetes, our target is the blood pressure, our target in LDL dyslipidemia. Of course, we have a target in free T4. Keep it, please, in the upper limit in the reference range to avoid the fetal goiter and hypothyroidism. A combination to give LT4 and antisteroid is not recommended at all in all medicine, except in this situation, which is isolated fetal hyperthyroidism. In isolated fetal hyperthyroidism, you can give antithyroid to treat the fetal hyperthyroidism, and you give the LT4 for the mother. What about thyroidectomy? It's allowed in the second trimester if the medication is contraindication or if the medication is of no value, especially if the TRAP is 3 times and the fetal hyperthyroidism is present. The TRAP is very important to differentiate between the Graves and physiological. It's elevated usually means Graves disease, and the follow-up, again, like gestational diabetes, we need a timing to search for the TRAP. They recommend to search it in the 18-22 weeks, and then repeat again in 30 to 40 to 34 weeks again to have another look, especially if it is elevated. Take-home protocol, again, it's conclusion of all the lecture, as I have said. Preconception, you have the 3 modules. You can give radioactive, you can have thyroidectomy, you have antithyroid drug. First trimester, please use propylsalicylate and tell your patients that the propylsalicylate is not used drug nowadays except in 2 conditions. If you have thyrotoxic crisis because the conversion, or in pregnancy because it is safer than methimazole or carbimazole. Second trimester, we continue the same management. Either keep the propylsalicylate or you can shift to methimazole. And third trimester, continue again on your medication and then do a TRAP. Have you seen the side box in the 32 weeks, the TRAP negative and the TRAP positive. If you have TRAP negative with euthyroid, in this condition, consider discontinuation of your medication, and postpartum, as we said before, we can keep either medication for our lady, or you can stop if it is euthyroid and the TRAP negative. If it is TRAP negative with hyperthyroidism, the same as TRAP positive, in this condition, you continue the medication, postpartum, continue the medication, and keep eye on the thyroid profile. Thank you, Mr. Chairman.